So this one's going to be focused a little bit more on how we utilize testing, testing a little more appropriately in order to better diagnose our patients. So we were kind of talking about things like specificity and sensitivity and all of that for our tests, and how we can actually apply that a little bit more straightforwardly. And so looking at this, we're going to see that, how do we learn about new things? What's where the medical research comes into play? So where we learn about new testing, where we learn about new things like, or for instance, we did the lab the other day. We talked about the CURB 65 score, right? What was that telling us? Should we admit these patients with pneumonia or not? And so, but where did that come from? Well, it came from a research article, right? They basically were looking at to see what were the things that were most likely associated with bad outcomes in these patients with pneumonia that necessitated them being put into the hospital, right? And so this is where they came up with things like odds ratios and risk ratios and things like that to say, okay, well, these are the 5 things we really care about because they are most predictive of someone needing a hospitalization, right? And so this is important to stay up on this information, and as you get into your own specialties, whatever you decide to practice in, you'll get into that specific niche, right? You can't read all the medical literature out there, but you'll specialize and be able to know what's in your particular field there. And again, as we are learning more, we're getting more into evidence-based medicine, following the guidelines, following all the up-to-date stuff that kind of tells us what we should be doing as best appropriate for our patients. And that includes the diagnosis aspect of it, right? Including picking the right tests, and when you do those tests, how you interpret those tests in order to make sure you get the right diagnosis and managing your patients appropriately. So there's this thing called Bayes' theorem. We've possibly have briefly alluded to. Anyone remember what that means by any chance? So basically what it's going to be doing is it's helping us with utilizing the specificity and the sensitivity of a test. It's helping us to determine, once we have some amount of information, usually it's like the prevalence of disease within the population, if our patient has an abnormal test that comes up, what is the likelihood that they actually have that disease in question, okay? So essentially that's what's helping us out with. And so basically saying, and we're going to talk about positive predictive values and things like that. That's really going to be one of the big things we focus on with here. But basically, because when a test comes back positive, you would likely think that your patient actually has that disease, right? Is that always the case, though? You know that's not, right? Especially when you have really low prevalence sort of disease states, right? We know that there's a high false positive error rate. Even if you have a test that's, say, 95% sensitive, you're still going to get some false positives, false negatives in those testings. I'll show you some examples of that in just a few minutes. But again, when we get a positive test, what's the likelihood that our patient really has the disease? And if it's negative, what's the likelihood they actually don't have the disease? And Bayes' theorem kind of helps us with this. And so, we'll be able to do these kind of calculations on the exam. No, we're not going to do that. But most people look at that and they're just like, I can't do that. I'm not going to be able to utilize any of that. But it's really not that difficult, right? It's really not that hard in order to use that information to make better assessments. And so we're not going to throw in the towel. We're going to try to actually look to see how we can utilize this information to help us out. And again, positive predictive value is what we're really going to be determining here. And so basically what we're trying to say is, by starting with some kind of preconceived idea of how prevalent a disease is in the population, and applying that to our tests by knowing the sensitivity and specificity, which is reported through things like literature and things like that, it'll give us a better idea of what's the actual likelihood, and do we need to do follow-up testing, or are we done? Can we stop right at that point there? And so we're going to find that, for instance, even if you were to say do a very general screening exam, so for instance, I mentioned if we're considering, say, an Ebola outbreak in the US, and we ask patients, hey, have you been to Sierra Leone recently? Not every single patient that says, yes, I've been there recently is going to have Ebola, right? You're going to get a lot of false positives in those cases there, but that can still be useful for initial screening programs. It's what you do afterwards and how you follow up with subsequent tests to really give you a better idea of what's going on there. Here's an example where they were doing kind of old school testing for tuberculin or TB, where basically they had some antigen they were putting on these little tines, these little forks, and they were piercing the skin, and they were looking to see what kind of inflammatory reaction would be happening there. And so basically, we already have a pretty good idea of, say, what the normal prevalence of TB is within the population. We get that from studies and things like that. And so then by knowing also the sensitivity and specificity of the test, it can give us an idea of, if someone did show positive in this particular type of TB test, what's the actual percentage of those people that truly have the disease there? And using Bayes' theorem, that can actually help us out pretty significantly with this. And so we're going to try to see, okay, if a kid did test positive with this type of test, what are the percentages that he's actually going to have, he or she will have that actual, will have TB. And so you'll see here that test that we're just mentioning has a 96% sensitivity and a specificity of 94%. Now, does that sound pretty good? Sounds pretty good, but you're going to see, even if you have a really good performing test, that if you have a disease with very low prevalence starting out with, you can still get a lot of bad data or a lot of bad information. So for instance, I'll show you how this actually calculates out. If you think starting out with that TB has about a 1% prevalence within the population, looking at that, about 13.9% of all the people that test positive actually have the disease. That means there's going to be a lot of people who are testing as false positives, and you don't want to falsely think you have TB when you actually don't, right? Because then they have to potentially go on medications or do follow, say, chest x-rays, all kinds of things. You don't want to have to do that. So don't get scared by the table here, right? It'll make sense of it. Basically what this top half is basically trying to tell us is saying, okay, what's the actual sensitivity and specificity of the test? Remember talking about false and false positive error rates, false negative error rates, things like that. Basically it's going to be determined looking at our sensitivity and specificity. And again, we're putting in our prevalence here. So these are the things you have to have in order to put it into a Bayes theorem, right? We're not actually doing the math ourselves, but what we can actually figure out is that if we had a population where we had a 1% prevalence, let's just take that as an assumption that yes, we're doing 1% prevalence here. That means if you were to test 10,000 people, that 96 people should actually have true TB, right? So they have the actual disease and they actually test positive here, right? But remember, you're going to have a relatively high false positive error rate because of the fact that it's just such a low prevalence. And so you end up having 594 people that did not have the disease that actually still test positive, right? So that means when you actually take that 96 divided by that 690, the total number of people with positive results, only 13.9% of people would actually have the disease. So based off of this information, if you had a patient who did this test on and they tested positive, would you immediately conclude that they have TB? No, the odds are just not in your favors in those cases. There's much more likely they do not have the disease. But what you can then do is follow-up testing using this information and then come up with a better result, as we'll see here in just a moment. So again, what you need to know is, again, first off, the sensitivity and specificity of your test. You need to know the prior prevalence. And sometimes you are making an assumption on that. Sometimes you're making a guess. Sometimes it is well published. It just depends on what you're actually looking for. But again, when you are, say for instance, looking at things like community screening programs, they're helping us to determine, say, what the prevalence is within a group. You'll typically find that you'll do kind of multiple rounds of screenings, and the first time you do the screening, you'll typically get a whole lot of cases. They're popping up all at once, and those are typically going to be the prevalent cases, right? Those are people that have already had the disease for a period of time. You're just now capturing all of them. Usually when you're going and doing a second round of screening, you get a few extra cases that have popped up, but those are usually new diagnoses. And so in those cases there, we'll talk about those as being incident cases. Mainly for Bayes theorem, we're going to be focusing just on using the prevalent cases within the population to give us an idea of what the actual true prevalence is. So let's say we were going to have, we have a clinician, they're kind of uncertain about a diagnosis, and we get a positive test result coming back, right? So something was a positive, let's say for instance, we were doing like that sim yesterday, and we had that COPD exacerbation, right? And then remember what the white count was, that patient? Was that a little elevated? Was it like crazy high elevated? No. So again, it's one of those things where sometimes you look at a value and just like, well, it's abnormal, but do I actually care about that abnormal result, right? So this is where some of this information can really help you out with that. So in the case of something like a white count on a CBC, in order to diagnose a patient with an infection, you're going to find that it may be pretty sensitive. You're going to be able to capture a lot of people based off an abnormal result, but may not be all that specific, right? May not be able to really identify who really has the disease and who doesn't in those cases there. But anyway, so in the clinical setting, though, what we're going to find is that, again, prior prevalence is what we're going to be using based off of community studies and things like that. It'll give us an idea. The actual prevalence is always going to be, it's hard to know with 100% certainty, but again, we can usually at least start off with a reasonable estimate based off of some of the data we have available. So let's say we are going to use this and actually apply it to a specific circumstance here. So let's say we have, we're working at a general medical clinic. Patient comes in, he's complaining of fatigability and has a history of kidney stones, okay? And so you want to decide to work up the patient for, say, hyperparathyroidism, okay? So how do we go ahead and do that? And then what's an easy test you can look for if you had a patient with hyperparathyroidism that you could do just as initial screening? So hyperparathyroidism. So like you could do a parathyroid level. That's kind of expensive. What could you do before that that would be a little bit cheaper and easier to get? A calcium level, right? So you can do a calcium level. Remember we were talking about that with some of the previous lectures. We were talking about how calcium even though it's elevated, doesn't mean that a patient automatically has hyperparathyroidism, and just because it is normal doesn't mean the patient does not have hyperparathyroidism. But you start off with the easy stuff first, right? And again, do you start off with highly sensitive tests or highly specific tests? Highly sensitive tests, because you want to make sure that you at least try to capture everyone who's going to have that disease if it's present, even though you may get a lot of false positives there. So let's say that we're going to have, let's just say we're going to go under the assumption that the prevalence of hyperparathyroidism in the population is, say, 2%. Okay, so that's going to be our prior prevalence we're going to be putting into Bayes' theorem there, just like we saw 1% for TB in that previous example there. And so basically what we're going to call that is the prior probability. So starting off initially, you have that prevalence or prior probability. That's what you're going to feed into Bayes' theorem to begin with. And so basically what we're going to use then is to look at the calcium level to see if it comes back abnormal. And we already know that yes, it's a highly sensitive test, but it may not be really specific there. And so we're going to find that, yeah, that test actually did come back positive, and the patient had, say, a calcium level of 12.2 milligrams per deciliter. Now again, you'll see that the patient, what's the probability they actually have hyperparathyroidism just off that one test there? We can actually put it in based off the sensitivity and specificity of those calciums, right? And so basically what it's going to help us to do is learn how to better interpret those results to see that, hey, do we need to do further testing? Do we not? What do we need to actually work with that? Okay. And so looking at this, we're going to say that the serum calcium test has a 90% sensitivity and a 95% specificity. And again, these are just kind of made up numbers, but they'll kind of illustrate our points here. And again, if you have a 95% specificity, it means that you're going to have a false positive error rate of about 5% there. And we'll put it into that 2x2 table, and it'll make a little bit more sense there. But basically what we're going to find, we actually put it in, and again, starting off with our 2% prevalence and our sensitivity and specificity here, you just feed that in, and what you end up getting is that patients who actually have the disease, say, and again, if you were to apply this to, say, like 1,000 people, 18 of them, the test positive would actually have the disease, 49 would not, and so when you actually plug that in to see what that positive predictive value is, you end up getting 27%. So that means that a quarter of those patients that had a high calcium, roughly, would have hyperparathyroidism. But can you finally say that's a diagnosis? I'm done? No, but now you can do follow-up testing and see how that's going to be affecting the follow-up test to see if that increases that positive predictive value or not. So now what we can do with that 27% of that positive predictive value, that is now what we're going to call our posterior probability. So initially the prevalence is the, what is that? What do we call that? The prior probability, right? So we're talking about that as being the prior probability, and now we have the posterior probability of 27% based off that positive predictive value. What I can then now use that 27% as is my new prior probability and put that into a new Bayes theorem by using a different lab test. So now let's say I have the positive screening with calcium. Now maybe I want to go ahead and do parathyroid hormone level. Again, it's more expensive, so we wouldn't want to do it for every patient. But now that I have that high calcium, now my index of suspicion is raised. I say, okay, let's go ahead and do the PTH level. And so we'll find that that test has a 95% sensitivity and a specificity of 98%. Remember, we start off with highly sensitive tests, and what do we work up to? High specific tests, right? So spin and snout, so don't forget that. And basically what we're going to see here is by plugging that 27% as our new prior probability, we're going to see how that changes our results here. And so looking at this, now we're starting off with 27% instead of 2%, because again, that patient had a positive calcium level, and we use that predictive value from the first Bayes theorem. Now we plug it in here, and now look what we end up getting. So of the patients, say you apply this to 1,000 patients, those that have the disease, they're positive, 256 of them, only 15 patients would come up as a false positive. This looks a lot different than what we saw in the last one, right? That's because our prevalence is really jacked up quite significantly from the last time we did this, from 2 to 27%, which now means that if the patient did test positive, they had a high PTH level, it would mean that they have a 94% chance that they actually have hyperparathyroidism. Do you feel much more comfortable with 94% versus 27%? Yeah, you can probably reasonably say, yes, they had the disease at that point, okay? So see how that works? You start off with that prevalence as your prior probability, you end up getting a posterior probability, then use that as your new prior probability, okay? You do that as a stepwise approach until you come up with your final diagnosis there. Now again, why did it raise up so much? Mainly because the prevalence went up significantly, and also we had a much more specific test. So it went up, say, from 95% to 98%, such that it's going to make it more specific, meaning that if the patient's negative, they probably really are negative at that point there, okay? It's a highly specific test to rule a disease in. So if they test positive, that's it. Okay, and again, you're going to find, just like we were running in the sim yesterday, we said, what labs do you want to get? And all of a sudden I hear just a litany of CBC, CMP, UA, TSH, blah, 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 just all the lab tests. And again, you have to think about judicious use of your labs. Like, does it make sense to get every single one of these in, depending on the setting that you're working in, right? In the ER, am I ever going to get a cholesterol panel for a patient who's in the ER? Probably not, right? It just doesn't make sense. Patients usually don't die from hypercholesterolemia. They die of the consequences of that, but they don't die from that specifically. So you'll kind of figure that out as you go on. And oftentimes when you get a lot of lab results all coming back at the same time, it's difficult to make heads or tails because some things will be positive, some things will be negative. And so you could order everything in a sequential sort of manner there, just like I did with the calcium followed by the PTH level. What do you think it does for the time it takes to actually make a diagnosis? Extends it out, right? And so oftentimes you may not have that kind of time. So most of the time you're going to be ordering the lab tests in parallel, but it's good to have an idea of like which ones are your really sensitive tests, which ones are your specific, and then sometimes you have to do the follow-up testing afterwards. So for instance, if you had a patient with chest pain and they had a positive D-dimer, then what might you have to do afterwards? Like a CT, right? And CT is very specific, such that if the patient that's positive, then yeah, they definitely have a PE at that point. So again, using a sequential approach, you start with the most sensitive test and then work your way up to increasingly more specific tests. That way we can make sure that we're starting off the snout and then all going up to the spin at that point, right? And again, may not always be appropriate, if you have a hospitalized patient and they're not really going to be going anywhere over the next couple of days, yeah, you can think about a sequential approach versus if you're in the ER, you kind of want to get an answer right away and just order all your labs at one time. So, again, you'll find that by ordering in sort of a more sort of intelligent sequential manner, you may end up kind of increasing your overall accuracy. However, again, may not be the most practical state in those cases there. It just depends on the situation that you're going to be in. But anyway, remember, whenever you're getting a highly sensitive test up front, you're getting someone that's positive. What's important to remember is that there may be a lot of false positives in those cases there, right? So again, highly sensitive tests are going to kind of try to capture everyone, even though they may not have the disease. So you have to be able to interpret that appropriately and say, hey, you did have a high level here, but that does not mean that you necessarily have the disease in question, right? Okay. So one other thing I want to talk about in this section here is kind of walking into making decisions about your patients. Like, how do you actually weigh the pros and cons of something in order to determine what the best course of treatment for your patient is? So for instance, deciding like, hey, should I send my patient to go get surgery or should they wait? Right? Oftentimes it can be very difficult to make those sort of decisions, especially if it's something that the consequences may not be seen for several years in some cases there. And so we're going to talk about decision analysis and how it can kind of help us to make a little bit more better informed decisions there. Okay. And so we're going to look at the kinds of data that goes into that, look how we kind of weigh our options in terms of like adverse effects, looking at how we're weighing probabilities and things like that. And so again, it gives us a better idea of how we make a better decision based off probabilities rather than just saying go with our gut feeling, because oftentimes we make poor decisions when we just go with our gut, right? Unless you're doing a test, in which case you should always go with your gut. Don't change your answers, especially if there's a epibio test coming up, go with your gut, right? Anyway, so let's talk about how we're going to be setting up these decision trees here. So one, we're going to be kind of identifying and sort of setting the limits of the problem. I'll show you an example of this in just a moment. You diagram out the different options that are available to you, and then you'll obtain information kind of concerning each of the options that will be laid out there. You'll look at comparative utilities of a value, right? When I say utilities, what does that mean, do you think? Could be life gained, it could be, getting rid of a symptom, could be lots of different things, but utility, usually good things that are happening for the patient. And then we'll talk about sensitivity analyses you can perform sort of after that. So when identifying the course here, again, we're going to be talking about sort of alternative clinical decisions. So again, if you're deciding between surgery and not surgery, you have to figure out what are the sequelae that could happen as a result of those decisions there. And so the example we're going to use here is if a patient has what we call silent gallstones, or they have evidence of having gallstones, but they are asymptomatic at the time. The question is, well, should I go in and remove the gallbladder, or should I just let it ride, right? So, and basically, the decision is, well, if the patient's asymptomatic, like, why do I need to go get surgery? And so you have to be able to make that decision, okay, well, what's going to be best for this patient based off of the probabilities, what is likely to happen, what is unlikely to happen, and which is going to be best for them overall. And so we're going to see how we'll read this, and I'll kind of just show you the picture here. Basically what you're going to do is starting off at this decision point here, right? So again, you're deciding, do I want them to operate now or do I want them to wait? And so deciding to operate now, of course, will carry some risk with it, right? So there is always a probability of death. Is it ever 0% if someone goes for surgery? No, someone could have a bad reaction. I had one patient who I believe received like lidocaine as part of an anesthetic for like a dental procedure. Kid ended up coding halfway through and ended up dying. Right? I mean, like freak accidents happen all the time, even though the probability is quite low. So let's say, for instance, that the patient goes for surgery. The probability of doing that course is 100% because I said yes, they're going to surgery, and their probability of death is, say, based off the literature, 0.4%. Okay, so very low probability, but still a risk, right? Versus if they wait, looking at this chance node here, you're going to see that they could go down several different pathways, right? So they could just remain asymptomatic the rest of their life. And if they remain asymptomatic, what's the probability of death occurring because of that? Nothing, right? 0. So again, this seems like it's like a pretty good option, right? 81% chance they're going to remain asymptomatic, no problem. Versus biliary pain, maybe there's a 0.4% chance death associated with that. Maybe they have other complications thereof, maybe say 10%, versus if they develop cancer, then let's say that would be 100%, right? So this is the probabilities of death associated with each of these outcomes, and then here is the probability of that outcome actually occurring here. So the chances of them getting cancer from these silent gallstones is fairly low, even though the risk of death is high with that one, right? Versus they're asymptomatic, that's the most likely course, but there's no chance of death associated with that, right? So we can actually then look to see how these stack up with one another by comparing the relative weights of the probability of these things happening versus the utility or maybe loss of utility altogether to see which one is the better course. Should you tell your patient to go to surgery, or would you tell them to wait it out? What do you think you would tell them based just off looking at this? Think surgery? Why'd your gut tell you to do surgery?
Force. I mean, I guess there's better analysis you can do.
Mm-hmm. It could be, but we'll look at that. But again, sometimes it's good to just kind of get us like, well, how would I think about this? Like, what would I tell my parent to do? If I tell them to go to surgery, tell them to wait it out. Wait it out? Why is that? Yeah, there's a high likelihood that they'll remain asymptomatic, right? So I don't know. Let's look to actually see how this actually turns out. And again, this is basically just kind of going over what we talked about. Again, comparing the relative weights of the probability of something happening versus the actual risk of death associated if that actual thing happened. And again, these are all just numbers we're just kind of maybe coming from historical data, or just kind of maybe we're making up in some cases. And that's when we'll talk about sensitivity analyses and how we can sort of see how robust these decisions are, right? Basically, though, when you're looking at the probability odds, if you have multiple outcomes, they all need to equal up to 100%, right? Just like the surgery route was 100% because that's the only outcome there, versus the other one that had to add up and they should be all 100% altogether. So again, utility is that final outcome that would be obtained, right? So again, death is obviously doesn't sound very utilitarian, but certainly you can look at it either way there. So again, you could be looking at a negative outcome, you could be looking at positive outcomes as well. So for instance, you could look at years of disease-free survival. Larger values would have greater value, versus if something like death, lower values typically have more value associated with that, right? So it just depends on the outcome that you're specifically looking at. Overall, though, our goal is to try to make sure that we maximize utility, make sure we're giving the patient sort of the best outcome possible. So looking at the decision tree, again, the final outcome gets expressed as that negative utility. In this case here, it's that probability of death. Again, the surgery was only 0.4%, so very low probability, but still a probability. And then looking at the other outcomes, you see it range anywhere between 0 all the way up to 100%, right? So what we can do, though, is then we can also, once we actually get the numbers there, we can also actually change the variables a little bit. So what if we change maybe the risk of cancer, say, from like 0.5% to, say, 2%? And then comparing that together, right? So by kind of doing that and looking to see like, well, do you get the same results every time? Then that means it's a very robust sort of analysis, meaning that, yeah, even if I fudge the numbers a little bit, they still come up with the same outcome. I still think they should go to surgery. I still think they should wait. That tends to be a pretty robust sort of thing there. Versus if I change the numbers slightly and all of a sudden I get wildly different results, that may mean that you need to kind of go back to looking at the analysis saying, well, okay, well, maybe I could try to redesign this a little bit, maybe make it so it's a little bit more, makes a little bit more sense, right? But let's go ahead and look at this. Also consider the utility values, right? Look to see like, okay, well, are these actual outcomes, do they make sense based off what the published literature is, what the actual data you have available is there? Again, sometimes these estimated probabilities, they're just estimates, right? So things can change over time. You have to look at the specifics of it, right? Okay, so let's actually look at this. How would you actually come in and weigh those two decision points together, right? So again, it's pretty easy for the surgery route. We already know that the probability of death is that 0.4%, so that's easy enough. When you're actually doing it based on the other decision to wait, here again, you're averaging out the risk of death overall, right? So again, you're taking that 0.815, so that 81.5% chance that it remains asymptomatic, multiplying it by that 0% chance of death, right? So that's not contributory. Then adding up all these other ones, including the cancer one, which is going to be skewing us, you can see here that overall ends up being 0.009. So looking at that risk of death from waiting is 0.009 versus if you go to surgery is 0.004. So which one appears to be the worst outcome? Waiting. So then you can make that decision. So, okay, well, actually, based off the numbers, it looks like even though there's a small chance of death with surgery, it's still safer than if you just waited it out and never had it done. So sometimes that can be used to convince your patients to say, hey, yeah, there's a very small risk, but actually the risk would actually be higher if you waited. Again, you could then run through several different sensitivity analyses and kind of fudge the numbers a little bit to see, okay, well, if I change this, how does it change the outcomes, right? Because again, these numbers are not always hard and fast. Sometimes they could be assumptions you're making, kind of best guesses if possible. But again, if I change those numbers and it keeps coming up that it looks like waiting is the worst outcome, then I would know that's pretty robust and say, okay, yeah, I think surgery is definitely the best option for you based off all these analyses we ran through. Okay, kind of make sense? So again, trying to figure out what is the most utility for the patient, and that can lead you to make that decision or help the patient make that decision. Yeah, I think surgery is right for me at this point. Okay, so again, just basically saying that based on this outcome, it would make sense to go ahead and get surgery done because that risk is overall lower. Again, it's a one and done kind of thing. You don't have to worry about it ever again. Okay. Okay. So again, you're going to find that a lot of other factors will influence that. So for instance, if you're looking at things like money, if you're looking at things like recovery time, other adverse effects of different things, depending on how you're factoring these things in, you can come up with wildly different results. But it's important to kind of figure out what's right for the patient, what's right for that situation, and kind of coming up with what the best idea is, right? Looking at stuff like this, things like gallbladder, death is fairly low risk from that thing. But what if you were dealing with something with very high risk of death, like saying getting a radical treatment for your type of cancer, right? So again, for patients who maybe don't have long to live, they want to try the most aggressive treatments possible because it, again, provides them the most utility potentially. So it just depends on the clinical situation and how this is going to apply to them. Okay, so any questions on that? All right, so let's do a 10-minute break and we'll come back and we'll do our review. Looking into our review, so first off, remember incidence and prevalence is certainly an important concept to recall. So for instance, if we're looking at this graph here, looking at the prevalence and incidence of HIV as time went on. Remember when you're evaluating this, right, if we were looking at, say for instance, in the year 1984, which portion of this bar, or let's look at 1988 instead, look at this portion of the bar, which of these would be the prevalence of HIV? Because remember, the darkened parts here are the known patients that had already deceased. The white bars are the patients who are still alive at that time, or at the end of this study at that point. So basically, if you'd added up all the white portions here, that would be basically the prevalent cases, because everyone else had already died at that point there, right? If you were to just look at the number of, say, incident cases for the year of 1988, which portion of the bar would that be? That would actually be the full height of that particular bar, right? Because those are all people that got diagnosed in that particular year. So remember, prevalence is at a snapshot in time, how many people have the disease in question. If you're looking, say, over a period of time, how many new cases pop up? That's called what? Incidence. Those are incident cases, right? So you can look at like incidence rates, and you can look at things like that. You guys recall when we talk about incidence density, what that referred to? That's when you have things that happen multiple times and you were to follow, say, several people. Say, for instance, you followed cases of pneumonia, or let's say COPD exacerbations in someone with emphysema or chronic bronchitis. If you were to look at the number of times, say, for instance, you followed 10 patients and they cumulatively had, say, 20 admissions over the course of a year, you'd say 20 exacerbations per 10 people a year, right? So remember, the incidence density can happen multiple times to somebody versus if it was like death, again, that's just a one-time kind of thing there. Okay, so looking at some review questions, we were talking about the beams model. That was in the early portions of the epi section there. What is this a useful paradigm for? And again, if you can look forward and get all the answers, but I would try to think through it now with me to go through this. What do you think? Is it good for allocating public health resources? Are we assessing the impact of things like herd immunity? Are we determining the role of social policy? establishing importance of social contacts, or evaluating etiologic factors in disease. That's going to be E in this case here, right? So remember that Bing's model is looking at things like environment. It was looking at things like spiritual beliefs, social practices, biological things there. It's looking for the reasons why diseases occur and trying to figure out like what was the actual factor here. So for instance, they saw, say lower cases of cardiovascular disease in Seventh-day Adventists, right? And then linking that back to the fact that they ate less red meat than, say, other religions potentially, right? That's part of that Bing's model. You're looking at the different factors that go into the etiology of their disease. Maybe a decrease in incidence, maybe increase in incidence, whatever the case may be. Okay. So again, and you're kind of talking about these, so you can go back through and read these. I'm not going to belabor those points there, just so we can get through all of these. Let's say we're looking at the number of new cases over a defined study period divided by the mid-period population at risk. What do you call that? It's a rate. So what would you call that? What type of rate is that? It's an incidence rate there, right? So again, you're looking at that mid-period population. That's always going to be a rate you're dealing with there. And remember, rates are very similar to risk if you're dealing with things that happen in a very small number of people, because then at that point your denominator really doesn't change much. If it's something that happens in 0.01% of the population, then it doesn't really change your denominator too much. It'll be very close to risk in those cases. There's really the big difference. Also remember, rates aren't great if you look at them over a long period of time, because then again, the more your denominator changes, the more different it's going to be than what your actual risk calculation would be in those cases there, right? What was the benefit of using a rate though? Remember the nursing home example. You can look at that force of mortality, or you look to see like when did a lot of these things occur? Did it all happen at the beginning such that you wiped out a lot of the people that would be counted in that denominator early? Did it happen over a pretty steady period of time, or did it happen all at the end, right? And again, in and of itself, it may not be all that interesting, but when you compare different things, if you're comparing different nursing homes or comparing people who had, say, a vaccine or a specific treatment to others, that's where those rates can be useful, right? You can look to see what the differences are between them, okay? This is going to be the total deaths observed in the population divided by the expected deaths in that population multiplied by 100. So again, it's what you actually observed over your expected. In that case, this would be a standardized mortality ratio. Remember, we were using these to help look at differences in, say, different populations. So maybe you're looking at expected deaths in the U.S., and then you're looking at the actual. So you can look to see that maybe in a particular city you saw that there were more, gun deaths due to homicide or something like that. Like that's where standardized mortality ratios can be useful there. Why do we multiply those numbers by 100? Yeah, get rid of the fraction essentially, right? So that way you can get an easier number to work with. It's easy for people to understand. And again, I'm just trying to illustrate some of the different definitions that may pop up on the test there, right? Because again, definitions are important to understand, because otherwise you can't really get much further than that if you don't know the lingo. Okay, how about the proportion of individuals with a given condition who die of that condition? Yeah, that's that case fatality ratio there, right? Remember, there's those different subsets. If you were to look at people who say, for instance, say imagine you're, let me get the pen, that's what I want. You can remember that one picture we were looking at was a square, and you're looking at, say, all people in the population is kind of like the entire square there, and then you're looking at people who, say, for instance, were exposed to, say, a pathogen. Is everyone exposed to a pathogen going to actually get the disease in question? No, right? But then as you get those smaller subsets of people who actually did get the disease in question, some of them remained asymptomatic, right? Some of them did not. And so the ones that became symptomatic, again, are going to be a smaller portion of that, and until eventually you get down just to the people that died of the specific disease. All right, so this would be the case fatality ratio here. This is a square. I'm coloring in very poorly, but that would be your case fatality ratio. Those are the people that actually had the disease, became symptomatic, that actually died from that. Okay, and again, what does that tell us? So I was comparing two different diseases together, and so one had a higher case fatality ratio. One's more deadly, right, than the other, right? So it's very helpful. You can look at things though like, okay, how many people actually caught the disease? You can look at things like virulence. You can look at rate of spread. You can look at different things like that by comparing those numbers together, right? This is the number of live births divided by the mid-period population. This would be mortality. This would be accrued birth rate, right? What could birth rates tell us? Can help with things like health of the population. Usually we're also looking at things like infant mortality rates and whatnot. And remember, you can look at different periods of time or different ages when those infants died in order to give you different information. So for instance, if you're looking at, say, the postnatal period, so say after the first month of life up until 1 year of age, if you're looking at deaths in that category, what did that kind of speak to? Was it maternal care during the pregnancy? These are the kids that are dying after the first month of life. No, because the kid's already been born, right? Yeah, talk about care at home, right? Did were there certain environmental factors that led to that child to die after they got home? Was it they not being fed properly? Were they in a bad environment? Who knows, right? Versus if you're looking at neonatal mortality rates, that may be giving you better ideas in terms of like maternal care. What was she doing at the time during the pregnancy? How healthy was that baby when it was first born? So again, different rates can tell you different things depending on how you're kind of slicing it up. But overall, again, telling us health of the general population, useful for looking at different countries and comparing them together, right? Okay. This provides the death rate within a defined age range. It's going to be the age-specific death rate, right? Why do we care about age-specific death rates? What was the example we used? Yeah, we're comparing different countries together. I think it was like Switzerland compared to like Ecuador, right? And then you saw it looked like people in Switzerland had a higher death rate than the people in Ecuador. You said, okay, well, if I want to be healthy, I'm not going to go to Switzerland, right? Which didn't make a whole lot of sense. But however, what was the factor there that was playing a role? They had an older population in Sweden, so if you actually looked at the proportion of old people based on whatever categories you divvied them up into, and you were to compare Switzerland versus Ecuador, what did you find with those age-specific death rates? It was actually higher in Ecuador because, again, even though they skew younger, if you actually look at just those age breakdowns, you actually end up finding that they were less healthy over nation overall in terms of those categories than you would say with something like in Switzerland, right? Maybe they had better access to care, things like that. So again, looking at age-specific death rates is taking out the fact that if you're just looking at crude death rates, things like age can be what? Can be a confounder, right? So again, looking at the overall demographics of the nation may be a confounder unless you control for that, and so I get an age-specific death rate, right? What other things could you control for if you're looking at, say, overall death rates in a country? You could look at things like gender, you could look at things like socioeconomic status, you could look at all kinds of different things there to try to control for that to see if that's actually playing a role or when you're making these comparisons together, right? That's just one example of that. Okay, let's switch gears and let's kind of look at more of a case sort of analysis here. So let's say we have a politician, this is topical for the upcoming year. Let's say we have a politician throwing a luncheon fundraiser serving up all kinds of seafood, including a salmon mousse. So it's good because it's not only salmon, but you also get the mousse in there. I had to cart them down from Canada. Just kidding, not that kind of mousse. Anyway, within 24 hours, 11 of the 17 diners experienced abdominal pain, vomiting, and diarrhea. Of the 11 symptomatic guests, 4 had fever, 7 did not. 5 had an elevated white count, 6 did not. 6 ate the shrimp bisque, 5 did not. 9 ate the salmon, 2 did not. And then 1 patient had to go to surgery for acute cholecystitis from an impacted calculus in the common bile duct. Okay. So of the 11 symptomatic guests, 10 recover within 3 days. The exception is going to be that person had to go to get surgery, recovered over a longer period of time, it makes sense. And then the guest at the luncheon shared no other meals at any other time recently. So that was the only kind of common point of contact there. Okay. So if you were to, does this seem abnormal?
Yes.
Why? Is it an epidemic? Why not? It's an abnormal occurrence, right? It's happening higher than what you would normally expect to see. But for more small scale things like this, what do you call that? Maybe like an outbreak, right? Or you could call it like a disease cluster maybe. Probably wouldn't call it a full-blown epidemic. Definitely not a pandemic, right? It would be kind of across the nation. But certainly this is an abnormal sort of occurrence here, right? So look at some of these other things. So how would you describe this? Kind of gave it away already. But would you call this just a coincidence until proven otherwise? Perhaps, right? But it doesn't really seem like it, right? It seems like there's a little too many things going on here that kind of raise the hairs on the back of your neck, like something's going on here, right? Kind of be kind of a sleuth. Can you say this is attributable to a bacterial infection? Not yet. We don't know yet, right? So again, it's kind of too early in those cases there. It is not an outbreak because the usual pattern of disease is unknown. In this case here, you don't normally expect people to eat lunch and then all of a sudden have abdominal pain and fever and cramping, all this kind of thing there. So again, in this case here, you don't have to know the normal pattern of disease, but for other things, so for instance, if you're looking at cases of flu that naturally occur during the year anyway, yeah, you would want to know the sort of the usual pattern of disease to see if what we're experiencing now is abnormal or not. Should this be investigated by the CDC? Probably not, right? We can probably handle this, but this is certainly a disease outbreak, right? Because again, it's happening in higher levels than what you would normally expect to see. Okay, and again, I'm not going to read all this because you can go back and read that for your edification if you forget what I say, or if my video is not sufficient, you can read that as well. But yeah, when would the CDC get involved typically?
Multiple locations.
Yeah, if it's something that goes across state lines, typically they automatically get involved. When else might they get involved? Not necessarily. Usually if there is a request, right? So again, sometimes you can have like a really odd occurrence of a really rare disease states popping up and kind of local state health officials kind of can't figure it out. Sometimes they'll request the CDC comes in and helps out. It just depends on the situation. But yeah, typically if it's like interstate lines or it could potentially affect other states other than the one where it originally happened, then CDC might get involved there, right? What would you consider the attack rate to be in this case? So what's our denominator here? 17, because that's the total number of people that were involved, right? And how many people became symptomatic? 11, right? So again, your attack rate is going to be 11 out of 17. You have to define what your denominator and your numerator is going to be in these cases here, right? Just like we talked about between risk and rates, you have to know what your denominators are going to be. Okay, so keep that in mind if you get questions asked like that. Again, mainly because our denominator is the total number of people who could have been exposed. 11 is the actual people who developed the actual disease state. And then what was the case fatality ratio for this case? 0, right? Because again, everyone recovered. So again, there would be no deaths associated with that. So not a very particularly deadly case of whatever this is. So in this case here, we're trying to evaluate it. So say you got called in to check it out from the DC Health Department. Come in and say, okay, well, what's the first thing I should be doing here? Should we close the kitchen temporarily? Should we define what a case is? Do we perform a case control study? Should we start doing stool tests, or should we submit food samples to the lab? We'll do stool tests first. Or if you define cases, what do you think? Well, first off, we got to define what our case is, right? So we have to figure out, okay, well, how am I going to investigate this? You know, the guy who had to go get a cholecystectomy, he might not really fit the bill there, right? He may have had abdominal pain, but does he fit the same picture as these other patients? Maybe not, right? So again, you have to define what your case is going to be there before you make any other rash decisions, because maybe it's not related to the kitchen. Maybe it's not related to anything you'd find in the stool sample. These are things you may do as a follow-up, but initially you have to define what your case is. You get your definition first, and then you can kind of go on from there, right? So looking at the best case definition for the disease here, what would we say? Would you say just abdominal pain, vomiting, and diarrhea within 24 hours of the state luncheon, acute viral gastroenteritis, staphylococcal food poisoning, onset of abdominal pain and fever after the luncheon, vomiting, diarrhea, and elevated white cell count? What do you think? Remember, you don't want to be too broad, you don't want to be too specific, right? If you go too broad, it might include all 17 people there, and that's not really all that useful there, right? You get too specific, and then you start ruling out people who may actually have the disease state, but maybe just didn't have those particular definitions being met there. So in this case, what we could say is if you have abdominal pain, vomiting, and diarrhea within 24 hours at that luncheon, that, yeah, that would be considered a case, right? That would warrant further investigation. Now, can that case definition change over time? Certainly, as you get more information, maybe you do find it as being related to something like staphylococcal food poisoning, then you can change that definition. But this is early in helping you trying to gear your investigation to go forward, right? Anyway, so could you say it's acute viral gastroenteritis? Again, we just don't know, right? So we couldn't say that's your definition because, again, that diagnosis had not been made yet. So suspecting that disease is a result of a common source exposure involving contaminated food, The investigators attempt to determine which food is responsible. What would your initial task be? Should I analyze food specimens in the laboratory? Should I close the kitchen, examine the food preparers, interview the asymptomatic guests to find out what they ate, or perform a case control study? What do you think? Again, generally starting out, you can go with the simple stuff, right? So figure out what people who actually fit that case definition, what did they consume? What did they actually have it? And then you can start to look for commonalities between them. You can start to look for trends there. Now, how would I run a case control study? How would you design that based off of these patients here? So I'd have my cases of people that fit that definition, and I would match them to who? The people who didn't become symptomatic. And then I could look back to see what the odds were that they were exposed to certain foods, right? So that would be one way to do it. Probably not real applicable here, especially with these small numbers. But that could be an example of a case control study. You could look to see, well, the odds of someone being exposed to that salmon mousse that became symptomatic versus the odds that they were asymptomatic and exposed to that mousse.
This seems to kind of parallel the Bayes theorem, where like you grab your initial net of people and then you ask like the specific things, or you get the specific. Is that fair?
In general, yeah, you want to cast a wide net early, and then you can start to tighten it up, right? So that's why, again, you start with sensitive tests. So by setting that, so let's say we're looking at this definition. All right, so when we're looking at this, which seems a little bit more broad, would it be just abdominal pain, vomiting, diarrhea, or they had the white count along with that? Because you saw some people were symptomatic, but they didn't have the elevated white count, right? So again, it gets a little bit more specific. You may lose people that may actually really be affected by this by getting way too specific in those cases there. So by, again, keeping it broad, that's why we start with really sensitive tests. It may pick up a lot of false positives. Then we can do further testing and kind of cast a little bit of a tighter net around that, and then we'll start to peel off those people that aren't really applicable, and then finally get down to our actual people with the actual disease, right? So yeah, it's very similar in terms of how we're going to be starting off broad and then narrowing down as we go forward. Just like when we do our PD labs and we're starting off with our differential diagnosis, like how long is that list normally when we do those grand rounds? It's like 30 things long. Someone, my favorite diagnosis, the one the other day was like the 71-year-old, and they're like, could be CF. And I was like, man, that's a really late diagnosis for CF. Like normally they get that at birth, but yeah, so very mild case of it. But again, you want to consider all possibilities. That's why you want to start with a very wide net. That's challenging your creativity and thinking outside of the box. And then once you start getting into it, then you narrow things down to what's more reasonable, what's more plausible, etc. Right? I love coming up with like really crazy disease states that could be responsible, and then be like, no, of course it's not that. That'd be crazy, right? You never know. Maybe it was a Komodo dragon bite. It's like, okay, well, probably not, right? Anyway, let's see. So we talked about interviewing the symptomatic guests, find out what they ate. Again, it may be premature to, close the kitchen, right? It may be premature to do any of these other things. You may do those eventually, but again, early on, you want to again figure out what the commonalities are between the patient's stories. So let's say we're going to do a screening program. And again, there's no further information, so I don't know, was it the moose, was it the bisque? Who's to say, right? We don't know based off of that, but it was definitely the moose. Anyway, so let's say we're doing a screening program, analog. So say, we talk about late look bias. What is that? Say we're doing like a survey. You're calling up people to find out, what disease states they have and what vaccines they received. It's a late look bias. Sometimes it's hard to catch things that maybe are very brief in nature, right? So again, if you have diabetes for the past 30 years and someone were to ask you what your health problems do you have, you'd probably remember that you have diabetes, versus if you had, say, cholecystitis 25 years ago, you may forget that because it hasn't really affected you in a long time. That could be considered something like a late look bias. If we're doing a screening program, what would be analogous to that? Would it be a length bias, because cases lasting longer are more apt to be detected? Would be recall bias, because only severe disease tends to be recalled. Be selection bias, because the program is selecting out asymptomatic illness. Selection bias, because the program only selects out for severe cases. Or would be spectrum bias, where the cases are clustered at one end of a particular disease spectrum. It should be length bias. So imagine you're doing a screening program, right? So you're kind of taking all comers here. So you're not really separating anyone out, right, based off of their symptomatic or asymptomatic. But again, what you're going to find is that length bias is important here because, again, if they, for instance, if you're doing a screening program trying to figure out who has the flu right now, the flu is a relatively short, contained sort of thing there. So I may not be able to pick up all the people who had the flu recently because they've already passed it, right? They've already gotten well. Versus if it's going to be something that is a lot more long-lasting, something like hypertension, you're more apt to actually be able to detect that at the current time there. So sometimes that can be affecting your ability to find certain things. Depends on how you ask questions. Depends on how good the patient's recall is in those cases there. Okay. When I say selection bias, what does that mean? Yeah, I'm kind of sort of introducing bias by maybe predisposing certain people to being in one group versus another. Say, for instance, I was doing a drug treatment and it was an orphan indication, meaning we don't really any good treatments for it. It's a rare disease, and I know this person has the disease and I really like them and I want them to actually get the drug. Selection bias, right? Sometimes it can be introduced by the study design, sometimes it can be introduced by people. It just depends on the cases there. Let's say, I always love this example here. Let's say we are doing a study and we want to determine the effects of drinking Mountain Dew on a teenager's ability or willingness to bungee jump from frightful heights. Okay, and so we're going to have a total of 500 teenagers, which that sounds terrifying. But let's say we're going to assemble them on the basis of bungee jumping status. So we have 250 people who are jumpers, 250 people that were not, and of the 250 jumpers, we found that 150 of them had done the do. Okay. And then of the 250 non-jumpers, only 50 of them reported drinking Mountain Dew, but most of the non-jumpers did report a preference for warm milk. Okay. Sounds nonsensical. This is hard science we're doing here, okay? Anywho, so which of the following statements would be true based off of this information, right? So jumpers and non-jumpers should be matched for beverage consumption. The absolute and relative risk of bungee jumping can be determined from the study. This is a cohort study. The study can be used to calculate an odds ratio, or unanticipated outcomes can be assessed in this study. What do you think? Question, how are we organizing these teenagers? We're divvying them up based off of a risk factor or off of the outcome? The outcome, okay? So this is a cohort study. Like a case control kind of study, right? So when we're doing a case control study, can we do things like risk, relative risk, things like that? What do we have to look at? Yeah, we're actually going to be looking at odds in these cases here, right? So, and again, we can't really look for unanticipated outcomes because we've already set what the outcome is, whether they were bungee jumpers or they were not, and then looking back at that risk factor of did Mountain Dew, were the odds higher of jumpers being Mountain Dew drinkers than if they were non-jumpers, right? Now, why should they not be matched based off their beverage consumption? Well, if you control for that, then you can't assess to see is there any real differences there, right? So again, depending on what the actual researchers are looking for, you want to match off of that. But what are some things that I could match for between the cases and the controls? You can do it on age, right? So I can match up 16-year-olds with other 16-year-olds. What else? Gender. What else? I can do it based off race. I could do it based off of they play Fortnite or not. I could play it Fortnite versus Minecraft, Fortnite versus Minecraft. You can do all kinds of things. But you don't want to do it based off of the risk factor you're actually curious about, right? You actually want more details on. Okay. All right. The odds ratio calculated from this study would give us the odds of drinking among jumpers to drinking among non-jumpers, drinking among non-jumpers to drinking among jumpers, drinking Mountain Dew to jumping, jumping among drinkers to drinking among jumpers, or non-jumping among drinkers to non-drinking among jumpers. I would like to hear that played back at like 2 times speed on the video later. What do we think?
We need like 5 minutes.
Yeah, give it about 10 minutes or so. The question on the test won't be as oblique as this is. But again, we're getting an odds ratio. We're looking at the odds of the jumpers, the odds of them being drinkers versus the non-jumpers there, right? Drinkers of Mountain Dew, yes, right? So the risk factors, did they drink Mountain Dew? The outcome is whether they jumped or not, okay? Now again, this seems silly, but you can see how this could apply back to other things as well. Smoking and lung cancer, right? You can apply this back to really anything. But again, I like to have a modicum of fun in this class, and this is the only outlet that I have, so it is what it is. Okay. The results of this study would indicate, so let's say we did find a statistically significant difference there. The odds were higher in the jumpers than the non-jumpers. Would we say that bungee jumping and beverage choice are associated? Say that bungee jumping and beverage choice are causally related? Would you say that bungee jumping influences a person's choice of beverage? The choice of beverage influences a person's tendency to bungee jump, or there's no association between warm milk and bungee jumping? What do you think? Is there a causal relationship here that we can identify? Why not? How could I identify a causal relationship? How would you design a study where you could assess for a causal relationship? I would need an experimental study, right? So I could randomize teens, and again, it's be difficult to do because if they're under 18, then you have to get assent, and I don't know that anyone would actually, any IRB would actually put the study through because they'd say, who cares? But let's say we care. It's sponsored by Red Bull or Mountain Dew company, whoever, but energy drink you want to use perhaps. But let's say they want to go ahead and say, if I wanted to do a causal relationship, I could randomize people to either drink Mountain Dew or not, and then look to see how many of them ended up going to bungee jump, right? What is necessary there to show that there is a causal effect there? What's important? Remember, time is important, right? So you have to show that they drank the Mountain Dew beforehand, and then that led to the bungee jumping. That helps to strengthen that association, helps to strengthen, there could be a causal relationship there. That would be the best way to do it. With a case control study like this, can we establish the temporal relationship? Maybe they started drinking Mountain Dew after they went bungee jumping. They're like, man, that was so cool. I'm going to start drinking Mountain Dew so we can show everyone else how cool I am. All right? You can't really prove that with a case control study because, again, it's all retrospective in those points there. So what does this show us? That we see that they're associated, but we can't necessarily get a causal relationship. Now, when I say something is a necessary cause, anyone know what that means?
Something must occur.
It has to be there in order for the disease to occur. Can you have tuberculosis without Mycobacterium tuberculosis?
No.
No, you can't, right? So that's a necessary cause. What about a sufficient cause? The thing is there, which can lead to it, but doesn't always have to occur there, right? So again, having the cause is not necessarily mean you're going to get the disease, but if it's going to happen, it needs to be there, right? So everything else gets lumped into what, though? Risk factors, right? So again, you have a lot of things that are risk factors that may be somewhat causal, but again, they're not a necessary or sufficient cause. But it's just like saying that smoking, is that a sufficient, a necessary cause, or a risk factor for lung cancer? It's a risk factor because, yes, it increases the risk of developing cancer, but you're going to see that there's a lot of people that are going to get cancer regardless, even if they never smoked a day in their life. So in those cases there, you could not say that smoking is either. Just because someone smoked, does that mean they automatically get lung cancer? No, right? So again, another reason why you can't necessarily call it that. Okay. Let's say, this is another fun one I like. Let's say we randomly assign subjects to 2 years of PA school. This is our intervention, our experimental group, or 2 years in graduate school, just nondescript graduate school. This is our control. And then we test for the evidence of mental health. So either yes, you have signs of mental health, or you don't. And then of 100 subjects assigned to each condition, you find evidence of mental health in 12 of the PA school group and 92 in the control group. This is taken from years back, so I imagine you guys are much healthier nowadays. Maybe not, who could say, right? An appropriate measure of this association of the study would be what? Should we look at incidence density, look at power, likelihood ratios, odds ratios, or risk ratios? What do they look at? What do you think? So in this case here is I put people into either going to PA school or they went to other grad school and look to see, do they have evidence of mental health?
Risk ratio.
You end up looking at risk ratios, right? Because I'm starting off with my groups defined. I've defined what the risk factor is of being in PA school or not, and then looking to see what happened, right? So again, in this case here, what is the incidence of mental health being detected in the PA school group? It's 12%, or it's 12 out of the 100, right, versus say 92% in the control groups. That would be the incidence of it. But then by looking and compare those two together, I can get the incidence, or I get the risk ratio, right? And so that's going to be very beneficial. Again, you can only do that with something like a cohort study or some sort of prospective experimental study, right? Very good. Let's say we wish to determine the proportion of myocardial infarctions that are fatal within 24 hours of their occurrence. You decide to examine the records of all local emergency departments and physicians' offices. You then calculate the proportion of reported MIs that resulted in death 24 hours or less after the patient was initially seen. And you discuss your plan with a friendly biostatistician, and he immediately points out, again, there aren't really friendly biostatisticians. This is why this is like a fake scenario. Usually like in caves, very darkly lit, and you have to give them snacks and they'll come and help you out. But they then point out, but your study there is going to be subject to which one of the following forms of bias? Would it be a late look bias, a lead time bias, measurement, observer, or selection bias? Based off this study design. What do we think? That's going to be a late look case of bias here. And so let's talk about why that is. Basically, we're only going to be detecting the cases of disease that are mild enough to be detected before death, because once a patient's already dead, then it can be difficult to capture at that point there. Also, are any of these people, the people that die from myocardial infarction, are they always seen in the ER, or are they always seen in the office? They may die at home, right? They may be pronounced dead at the scene. They may not be actually captured within that. So in those cases there, we call that a late look bias, and that could be leading some, may skew our numbers. It may not be able to get as good information as what we're actually looking for there, right? That would not be great. If we were looking at mosquito, oh yes ma'am.
Are you only selecting people that were brought into the
Yeah, so we said we examined the records of all local EDs and physicians' offices, right? So if you went to the physician's office, you got diagnosed with MI there, and they would capture you and say, did you die within 24 hours? Or if you showed up to the ER, diagnosed with MI, died that 24-hour period.
So is it not selection bias?
You would be selection bias if you were, I'm trying to think of a good way to explain or way to introduce selection bias. A different way to design the study. You could do that, or for instance, if you're only looking at, say, you were excluding certain geographical areas, maybe you're only looking at more affluent areas versus, say, like an inner city sort of area, maybe that would be a selection bias. So if you were looking at, say, poorer areas where they maybe not are seeking out medical care, perhaps you'll have a higher proportion of them that are dying, rather than if it's, say, a more affluent area where they're more likely to be kind of chronically managed, perhaps. That's one way I would consider it. And again, I'm going to edit all that time out where I was just trying to think of something, so it sounds like I came up with an answer like that. And this part as well, also. That make sense, though? Yeah, so again, how you're selecting those patients initially, so it's not necessarily, this is more like with the analysis of actually how you're collecting the data itself, yeah. Okay, if we're looking at the spread of malaria, the transmission, how would you consider the mosquito? Sound like Dorito, like we were talking about earlier, right? So the mosquito in this case would be counted as what? Be an animal reservoir, a parasite, surrogate host, a vector. It's a vector, right? Because that's one's actually spreading it from person to person, right? Very good. You should know that from your microbiome class you just finished up, right? Perhaps. I'm sorry? Anopheles. Ooh, sore subject. I'm gonna move off of that one. This is like TV again. Anyway. Which of the following would you think best describes the effect of vaccination against diphtheria when the disease was more common than it is currently? So back in the day, it was more common than it is now. How do we talk about the effects of vaccination? Say frequent exposure resulted in boosted immunity after immunization. Frequent exposure resulted in an infection against which vaccination was not protective. Susceptibility to severe infection redeveloped several years after vaccination. Vaccination resulted in hypersensitivity, or vaccination resulted in unusually severe clinical disease when immunity was not achieved. What do you think? This is cases I remember, especially like when sanitation got really good, like back in London when they were trying to up their sanitation rates, and actually found that like more affluent people are actually being affected way more by disease here. A lot of it has to do with the fact that basically susceptibility to severe infection redeveloped years after, because again, early on, while those patients were being vaccinated, they found that the durability of that vaccine was actually running out early. So they found that later on when they got exposed to it, they didn't really have any protection. Because again, what gives you better protection against disease? Actually getting the disease or a vaccine? Actually getting the disease itself. So these people who are having lower rates early on in life, once they lost that protection, then they found that once they actually acquired the disease, then it would really kind of wreck them a lot worse than it would be if they had gotten it earlier. So again, it's one of those things where you can see the unintended consequences of some of these kind of public health interventions, right? Okay. See, data reported for cases of relatively mild diseases such as chickenpox could generally be characterized as highly accurate because of active surveillance, useful for establishing prevalence but not incidence, valuable for detecting changes in pattern of disease, valueless because mild diseases are underreported, or valueless because most patients with mild disease do not present for medical care. I think there. So something like chickenpox that happens frequently enough, but do you really care if someone came with a thing of chickenpox? Would you say, wow, I should write a case report on this? No, because it's pretty run-of-the-mill kind of thing there. Do we do active surveillance for stuff like that? No, it'd be too costly. Right? We want to focus on things that are brand new or potentially really dangerous, things like that. So it wouldn't be necessarily good for doing active surveillance. We wouldn't want to do it for that. Do you think people underreport or overreport things like chickenpox? Underreport it, right? Because again, it's something that happens quite frequently. You wouldn't really think about it. So again, it's not really good for establishing prevalence, or it's not really even good for prevalence necessarily, because again, of that underreporting, you may not get a lot of those incident cases there. However, what is it useful for? When we look for changes over time, right? If all of a sudden a bunch of people are all of a sudden showing up with really severe cases, then that would spark some interest, right? So again, it's good to look at normal average trends, even though you know it's underreported. You want to look for changes over time in order to see that, okay, yeah, something weird's going on here, or maybe cases have gone down significantly, whatever the case may be. Okay, they still have some value, but they're not going to be as good as if you're doing like true active surveillance. But that costs time and money, right? Okay. How about this? So let's say we have the following deaths are reported in a population. We have 2,807 men aged 35 to 68. We have 4 deaths in non-smokers, 11 deaths in men smoking 1/2 pack of cigarettes per day, 18 in men smoking 1/2 to 1 pack per day, and 43 deaths in men smoking more than 1 pack per day. From this, what can we conclude? Smoking increases mortality. The relationship between mortality rates and smoking is linear. There's a dose-response relationship between smoking and death. To interpret the data, the age at death is required for each case, or to interpret the data, information must be expressed as rates for each risk group. What do we think? Can we say definitively that smoking increases mortality? What do we think? Actually, we end up needing to express these rates, or end up getting information to be able to express rates for each group here, because we want to see that force of mortality on each of those individual groups cases there. And again, that will help us to make kind of better apples to apples sort of comparisons. That will let us know that, hey, can we actually say that there is a dose response relationship? Is it linear? Is it non-linear? You can kind of figure that sort of thing out there. But again, this is sort of making too broad of a generalization just by kind of looking at those numbers. Because looking at it, it looks like, yeah, more smoking causes more death, right? But it may not quite be that simple, right? We're just kind of eyeballing it ourselves, okay? So again, here by using rates, you're going to be able to get the risk of death for each group there and be able to actually compare them to one another. That makes sense. Which of the following examples might represent a retrospective cohort study? So we have cases of lung cancer assessed for prior exposures. We have subjects randomly assigned to active varicella vaccine versus placebo, and we look to who gets chickenpox. Subjects with current angina followed for the development of myocardial infarction. We have subjects with prior radiation exposure followed for the development of lymphoproliferative cancers, and then subjects with skin cancer assessed for lifelong cumulative sun exposure. One of these would be a retrospective cohort study. I think A. I think D. What do you think? So with a cohort study, how do we divvy people up? Based on their outcome or based on their risk factors? Based on their risk factor, okay? So again, if you're looking at, say, like cases of lung cancer, such for prior exposures, that's a case control kind of study. You're looking to see what risk factors they had that led up to those lung cancers, right? So we're starting off with our risk risk factor, and then we're following them forward to look to see what outcomes they actually developed, right? It's still retrospective, right? You can do this with chart reviews and things like that, but which one of these would kind of fit the bill there? Would it be B? No, that's like an experimental study. It wouldn't really count. About C? These are, yeah, this is prospective. Currently, they have angina. You're looking to see who develops myocardial infarction. How about subject with skin cancer or such for lifelong cumulative sun exposure? Again, that's going to be more like a case control sort of study there. So this would be a case here where you're looking at previous radiation exposure. You'd be able to document when that occurred, and then to say, okay, well, when do they, and if they develop lymphoproliferative cancer there. This would be a case of a retrospective cohort study. Like I mentioned, my coral snake study was retrospective cohort because I was looking back at charts that had already been complete, looking to see did they get antivenom early or not, and then looking to see what outcomes they actually developed there. Okay. All right. If you recall, one of the PowerPoints we were talking about the Physicians' Health Study. It was a randomized, double-blind, placebo-controlled trial that we're looking at the effects of aspirin and beta-carotene on CV disease and cancer, as in those male physicians, 40 to 75 years of age. The randomization of the participants was performed to help achieve which of the following? Did it eliminate all bias, dealt with external validity, internal validity? Did it prevent confounding by known and unknown factors, or did it provide statistical significance? Internal validity? What do we think? What's external validity?
Generalizability.
Yeah, how well can I apply this study out to larger populations? So was this a very generalizable study? It was done in 22,000 male patients who are all physicians who lived in the U.S. who were 40 to 75 years of age. No, right? Because again, compliance is going to be pretty good in that kind of patient population. They're probably going to be relatively healthy compared to the general population. Like a lot of those things make it so it's almost not generalizable at all unless you have a very specific type of patient there. So external validity is not going to be the case here. Internal validity, yeah, it certainly can help to some degree, but the really big thing is it helps prevent confounding. And the reason why is that? When I randomize them, even if they have some differences in characteristics, they should balance each other out, right? Because again, people regress back to the mean. So as long as I'm starting off with people in this definition here and I'm randomizing them to the groups, even though there may be slight differences, they tend to balance one another out, and so the groups overall should look very similar to one another, okay? That does help provide some degree of internal validity in those cases there, which means it makes sense within the confines of the study, but certainly I would not call this an externally valid study. Does not necessarily provide any sort of statistical significance, and it does not eliminate bias. Right. Let's say we have a new disease from reported in the U.S. It's called maple syrupitis, and it's originating from Canada. It's been reported to have caused 5 deaths so far. Your hospital then initiates a screening for all patients. They're asking everyone who's coming in, have they been to Canada in the past 6 weeks? What kind of surveillance is this? Is it active or passive? This is more active surveillance, right? Because again, you're asking every single patient who's coming in, right? And maybe you have some governmental organization, maybe the health department is organizing that and checking in. See, okay, they call up each hospital every week and say, okay, did you have any people that met this criteria? Did they actually have the disease, et cetera? It's more active surveillance there. And then what phenomena might those first few deaths indicate? What do you call that? Yeah, the Iceburg Phenomenon, right? So again, you initially get those big high-profile cases right up front, the really deadly ones, and then typically there's probably a lot more people that actually have the disease, they just don't have it quite as severe. And so by doing those initial screenings, now by asking everyone who's coming in, have they been to the Great White North recently, you can find out whether you're more likely to capture those people who maybe are not quite so, have the disease and are not symptomatic, things like that. Make sense? So any questions for the exam? Which is definitely on Monday. Can confirm. Let me check the board real quick. What exactly does positive predictive value represent? It's a very good question. Can anyone help me out? So basically the positive predictive value is basically looking at, say you perform a test, right? We're looking at that 2x2 grid where you have people that have the disease, people that don't have the disease, and then comparing did they have a positive or a negative test, right? Basically what it's looking at is just looking at that positive row. Basically saying of all the people who tested positive, what percentage of them actually had the disease in question? Okay, so in the case where we're looking at abnormal calcium levels, we found that it was only like what, 20-some-odd%, 27%, I think. So if you had a high calcium level, those 27% had hyperparathyroidism. Okay, so that was a positive predictive value. As we then went and did the second round of Bayes' theorem with that, and then increased that prior probability, then it came up to be what, 94% or something like that, whatever it was. So again, that's what the positive predictive value. If you had that high calcium level and then you had a high PTH level, then you were 95% likely to actually have hyperparathyroidism. That's the positive predictive value. Okay.
95%.
Yeah, 95, whatever it happened to be for that particular case there. So it's that posterior probability you end up coming up with when you actually run it through the numbers. Okay. Any other questions? Besides, why are you so sad this awesome class is over with? But it's okay, we have more classes coming up. Your whole research career is going to be starting off with me for a lot of you. Maybe some of you have done some beforehand, but we'll get to work closely together during the summertime for your GP1. We're actually working on your research paper. You get a whole 10-page paper you get to write. You get to learn all about medical literature searches and how to evaluate the data, how to actually evaluate articles. It'll be great. It's a very fun course, and then it's all online too, so yay. And then your GP2 and 3 will be during your clinical year. We have a whole lot of research ahead of us, so just you wait. Any questions I can answer before I let you go? Again, please, I prefer constructive criticism on my evaluations. I want to hear how I can make things better. Maybe not for you, but for those going forward, right? Not a whole lot I can do for you at this point. It's a little late in the game.
How do we compare to your other classes? Like, what could we improve on?
What could you improve upon? More gifts, cash preferred, no. Every class it's kind of funny because every class is kind of the same, but they're also kind of different, right? So, PA students tend to average, kind of revert to the mean a little bit there. So you guys are on average awesome because we only let you in if you're awesome to begin with. But everyone has their own little idiosyncrasies, so it is what it is. That's the most political way I can say that. I like all my classes the same. Okay, I'll see you guys next time.